We've got a little schedule, so I decided to wait a few minutes, but we might as well get started, and hopefully we'll have an enjoyable set of sessions. So I am the first speaker. I'm Charmaine Williams from the University of Toronto. I'm in the Factor-Inwentash Faculty of Social Work, and as you see here, I will be talking about stigma and recovery from mental illness. Essentially raising some ideas about how anti-stigma interventions may contribute to positive outcomes for people who are diagnosed with mental illnesses. So the three main points that I want to make in my presentation today is first that I think stigma is one of the most pressing issues that we're dealing with as mental health clinicians, educators, and researchers. Somebody actually asked me this question recently, what do I think is the #1 issue in psychiatry and mental health? And I said stigma, because I believe it affects not only the people who are diagnosed, but it affects the healthcare system and what we have available to us and affects the culture as a whole. The second point that I want to make, which comes from the study that I'll be talking about, is that for diagnosed individuals, internalized stigma, what we're calling internalized stigma, needs to be treated psychologically, as people are doing, but also needs to be treated socially. And then third, the anti-stigma interventions, as we understand them right now, are not really adequate to the task, and I feel that they need urgent updating to shift from an agenda that's about building tolerance in the general public to one that's about engaging in human rights for people who are diagnosed with mental illnesses. So the research study I did was about stigma and recovery. It starts from the premise that when somebody is diagnosed with mental illness, the stigma that's against mental illness becomes a personal concern. Certainly there's a lot of work that talks about the profound stigma that there is against people who are diagnosed with mental illness. It's always been included in the classic work around stigma, and certainly hasn't seemed to be one. While we talk about improvements in our understandings and our acceptance, there's still, we know, quite a bit of stigma against mental illness, and it's very difficult to be a person who has a diagnosis. One of the things that I actually want to pursue in research is some kind of a project around disclosure and what happens when we disclose the mental illness. I think that is one of the most telling things in terms of identifying the stigma that still exists against mental illness. So once you become diagnosed with a mental illness, suddenly these things that have been social ideas around you become personally relevant. And you are set with the task of developing what I call a positive post-diagnosis identity. The emphasis there is on post-diagnosis partly because it's not so much, for me at least, as a social worker, it's not so much about identifying somebody as a person with an illness or a disease, but more that you have been diagnosed, which is a social act. It's an act in which whatever it is that's been happening to you has a label put on it, and there are implications for that label. And what people have to do is try to figure out what this label means for who they are as individuals and who they are as social beings. And part of what we've seen when we look at people post-diagnosis is that there can be many outcomes that are not necessarily positive outcomes. We think about people, for example, who we think of as being in denial, who refuse services, who end up in all kinds of bad situations because of that. We think of people who become somewhat engulfed in a patient identity and become completely wrapped up in this identity as a patient, and not necessarily a healthy, health-promoting type of patient identity. So this is why I've been interested in work on how you develop a post-diagnosis identity that promotes your health, that preserves self-esteem, that preserves self-image, and those kinds of things. Another important component driving this project was the idea of recovery from mental illness. Recovery has become internationally an overarching direction for mental health reform. So almost anywhere you look, people are talking about recovery-oriented mental health care. And a lot of what the recovery movement introduces to mental health care systems is an idea that while, of course, we hope for a day when we can perhaps talk about cures for mental illness, what we are focused on now is finding ways that people can live lives with purpose, hope, and dignity with a diagnosis, and not necessarily because all of their symptoms are gone. And any of us that have worked for a while with people who are diagnosed with mental illnesses knows that, sometimes symptoms go away, a lot of the time they don't, and people live with persistent symptoms. So the recovery movement is really about, without keeping in mind that life can be easier without those things, of course, that there are still ways to have quality of life despite the persistence of symptoms, and it's not so much about a cure as being able to find that quality of life. And so what I wanted to look at was how stigma was linked to this process of recovery, because although stigma has been studied in many different ways, surprisingly, I find that it's only beginning to be studied in terms of how it affects individuals and families who are affected by mental illness. There is not as much work around that as you would think. And then with this new recovery orientation, there hasn't been much work at all looking at the links between that and people's capacity to get to a place that they would call recovery. The study method was to recruit individuals who were diagnosed with mental illness, asking them to be part of a study that was about life after diagnosis. And this was a very deliberate recruitment strategy. I did not recruit from mental health care facilities or hospitals. I actually recruited from community newspapers, the type of newspapers that you would find, free newspapers that you would find in the subway and places like that, sorry, the metro and places like that, because I wanted to find people who had had the experience of diagnosis, but had not necessarily chosen to be affiliated with the mental health care system. I wanted a wide range of experiences. So I got people who had had one contact many years ago all the way to people who had been affiliated with the system for decades, you know? So I asked them to be part of the study about life after diagnosis. There were 65 individuals who participated in the survey section of this research, where they completed different measures, and then 20 people who participated in in-depth qualitative interviews. It was a mixed method study. And the topics of the surveys and the interview were around issues of hope. Like essentially the entry question was about how has diagnosis affected your life? And the scales looked at that in terms of people's hope, their insight into illness, which is something that we talk a lot about in psychiatry, which is really about whether people accept a diagnosis and accept treatment, their experience of symptoms, how diagnosis had affected their feelings about themselves, their relationships, things like that. So this is the socio demographics of the people that participated in the study. I'm seeing a typo in it right now. So as you can see, they were about half men and half women. If you look at both the survey phase and the qualitative phase, the examples were quite similar. And in fact, the people that participated in the qualitative phase were a randomly selected group from the people that had done the surveys. The things that I would call your attention to there is, well, first of all, I guess because it's Canada, we look at ethnic identity in terms of Aboriginal, white, and something we call visible minorities. So Aboriginal refers to people who are Indigenous in Canada, and racial minority, basically anybody who isn't white. And the study was done in Toronto, so actually we had quite good representation in terms of that population. Most of the people were single. People were fairly well educated, as you can see, a fair amount of people who've completed post-secondary education. At the same time, most of them being supported by some kind of permanent disability. And if you looked at the group, a mix in terms of 50 of the 65 people almost hadn't had a hospitalization in the past year. Some had had one, and some had had more than one. So a quite nice range. I was actually very pleased in terms of who was able to participate. So this is the data from the scales. So on top there's the correlation matrix, and the second table, table 3, is a regression analysis, both looking at associations between the various scales and RAS, which is the Recovery Assessment Scale. The Recovery Assessment Scale is a scale that's been used a lot around the world. It's the most used scale to assess recovery, but because recovery is relatively new, it's also relatively new. And it looks at these issues like hope and purpose and meaning and feeling, able to manage your illness and things like that. It does use illness language, but it's very focused on those other issues. So what I'd call your attention to here is first that if you look at the correlation matrix, you see that there are significant correlations between symptoms, insight, hopelessness, and internalized stigma. That's what the ISMI is, internalized stigma. And but if you look with a Bonferroni correction, first of all, the insight correlation doesn't hold. And I think the other important thing to note here is that symptoms actually have a relatively small contribution. So that 0.37 R value there tells it that there is an association, but certainly not at the magnitude that you would see between hopelessness or internalized stigma. So while symptoms certainly seem to be relevant in some way, they don't tell a lot of the story. And I think that's an important point, because a lot of people think that recovery still has to do with whether or not you are free of symptoms. And I think that this reinforces that's not the case. Okay, yeah, so looking at model 3 here in the multiple regression analysis, we see basically the same thing here. So actually in the final model, symptoms don't even remain relevant, and insight isn't relevant again. But once again, and I think just to summarize it here, the stigma and hopelessness are the things that really tell us the most about what's contributing to recovery, right? So, and remember, this is an internalized stigma scale. In terms of what we saw in the interviews, people certainly talked a lot about the impact that stigma had on their life. So for example, you know, in the upper right there, somebody talking about how brutal it was trying to keep their illness a secret, right? That they felt they had to keep it a secret. Upper left, I just felt it was a barrier some way. And I think it's telling that this woman says it wasn't even the illness that was stopping me, it was the people around me that were stopping me, right? And then finally, you know, in the bottom right there, it got me thinking of myself as not normal, which wasn't helpful. Now, part of what I want to call attention to here in these examples is that I really think that they're telling us that although there's a lot of attention to this idea of internalized stigma, what people are really describing is experiences of stigma, the anticipation of stigmatizing experience, the anticipation of discrimination and rejection, and really that they're talking about it as a social phenomenon, not so much as an internal thing that's happening with them, but certainly those social experiences or those anticipations have an effect internally. So to that point, what is stigma? First of all, I looked it up. Stigma is a Greek word, but then I thought so many of our words are actually. Being in Athens just makes me more aware of it. So what is stigma? A disgrace or stain on reputation. You know from Goffman's work, he talked a lot about the negative stereotypes and how it spoiled identity. Corrigan, thinking about stigma in the context of mental health, specifically talked about the link between stereotypes, prejudice, and discrimination. And Lincoln Phelan also in the same area, thinking about how not only is it about bad negative ideas and negative interpersonal experiences, but that it also becomes something that is attached to social stratification and access to economic, social, and political power. Right? So again, stigma is a social thing. It's not just something that happens between you and me. It's not just something that happens inside me. It has implications. It has material consequences. It has important social consequences. So when we think about stigma socially, that indication of difference that turns into negative stereotypes and prejudice that then becomes community devaluation and rejection, exclusion, and discrimination is what's been described quite clearly by these theorists. What I'm proposing is that what we're talking about as internalized stigma is really people's attempts to cope with all of that. Rather than internalizing it, and I'll say why I sort of reject that idea of internalized stigma. I reject it partly because I think it's becoming a psychological phenomena that we're deciding we have to treat in some way. And I don't think that really recognizes that what people are doing is trying to cope with the stigma. And that's really something that came from this work. And I was very fortunate as part of the study to actually have an advisory board that was made up of people diagnosed with schizophrenia, and they were the people who said this to me first. They looked at the internalized, the ISMI scale, internalized stigma of mental illness scale, there. They looked at the scale, and what they said to me is they're calling it internalized stigma, but really what this is a scale about people experiencing and expecting discrimination. And it was funny to me, until they said that to me, I hadn't really thought of it that way. And it's become clearer and clearer to me as I've listened to people talking about stigma, that this thing that we're calling internalized stigma is really an indication of their abilities to cope, or their attempts to cope with these kinds of things that we're talking about. And part of what we see there is negative coping, and some of that negative coping is withdrawal, social withdrawal. What I'm also very aware of is people beginning to sort of believe that they don't actually have entitlements to better treatment, so that type of thing. And then hopelessness and depression, right? So I'm partly proposing here that we need to change our thinking a bit about that. Instead of treating it like a deficit of the person, recognize it as an outcome of the environment, the social environment that people are living in. So how do we counter that anti-stigma? The kind of things that people talked about as changing the situation for them. One example was peer support. So on the left here, we have this person talking about being part of a group. It was a group for family members and individuals diagnosed with schizophrenia, and what a difference it made to them to hear somebody else who had actually had the diagnosis saying it's okay. That's when I believed that it was okay to have the illnesses, and that's when I said, okay, I have schizophrenia, it's going to be okay. And when I did that, my whole world opened up, right? And we've seen a lot of work about how peer support can help. Now, not everybody is going to take advantage of that, right? There are some people who distance themselves quite deliberately from what we would call the consumer community or the service user community in Canada. But for those that can benefit from it, you can see this is an example of how it could possibly be helpful and how it can be destigmatizing to hear other people who have actually experienced what you're experiencing saying, this is okay, there is life after this diagnosis. The other thing here that came out much more strongly, actually, was that social roles and social participation played a huge role in people being able to feel like they were moving into a place of recovery. Again, this is not necessarily that people are symptom-free, but when they were able to have some kind of meaning and purpose and hope and participation, this made them feel like they could work, like they were able to find quality of life. So this person who's quoted on the right is somebody who actually became a peer service provider in the healthcare system, and said, that's when I realized that this was not all a waste, all these years of struggling. Maybe I could give back in a way that's meaningful and productive. And many people talked about how things turned around for them when they were able to find a way to move out of their own suffering and give back or participate in a way that made them feel they had a meaningful role in the community. And that's a lot of what recovery is about, finding some kind of purpose and meaningful role in the community. But again, I don't think the focus is just on the individual somehow finding this role. We as a community have to find the spaces for people to have these roles. So the current state of anti-stigma intervention, and here I'm talking about North America, so I'd be interested if anybody has other thoughts from other places. In the healthcare system, a lot of the anti-stigma work is really around deciding how to position mental illness and mental health. So when I refer to medicalization, some people have felt that the more that you talk about mental illness as a disease like any other disease, this will remove stigma, because people will just think of it like a physical illness, and somehow that will make people, that will diminish some of the negativity around it. The outcomes on that aren't clear. At the other end, we have people who go the other side, demedicalization. So now we're not even going to talk about disease. We're not going to talk about illness. You see that in a Miles forum where people will talk about, mental health, and it drives me crazy when people will, not crazy, but it drives me nuts when people will say, this person has mental health, when I think what they really mean to say is this person has a mental illness, but they feel if they say mental health, that somehow it's less stigmatizing. And then if we go even further, that there are people who will just not even use any kind of medical language. So they talk about emotional problems, they talk about crisis, but never that language. Certainly in the public, and I think what people mostly think of when we talk about anti-stigma interventions is the type of public education that is done to sort of destigmatize mental illness, to get people talking about mental health. There's been a lot of work on that in Canada. And then contact, because that's been one of the things that at least empirically seems to make the most difference when people actually have contact with people who are diagnosed with mental illnesses and sort of have a sense of the people behind the label. We're not sure about how long that effect works, but certainly there is research that shows it works. And then for diagnosed individuals and families, now that we're beginning to think about the way that stigma affects individuals and families, really what we've done is sort of transform existing psychoeducation and group support interventions to now more directly deal with stigma, right? To talk more about stigma. Now, with the internalized stigma interventions, as I said, I kind of think that we're barking up the wrong tree there, that it's not so much about internalized stigma, it's about coping with the stigma. So I think if we redefined what people were experiencing as coping with the social and structural stigma, then the kind of anti-stigma interventions we could begin to think about is recovery focus, which is already happening, so focusing on hope, purpose, and meaning so that people can look towards that and have sort of reasonable optimism about the possibilities for them post-diagnosis. Some of the work that people have been doing is cognitive behavioral strategies to challenge what they see as the kind of ideas that people have, the kind of automatic thoughts and cognitive errors, to use their language, that are associated with internalized stigma or maladaptive coping to stigma. So for example, if you're thinking, I can never work again because I have a diagnosis, that there are cognitive strategies we could use to help people see that that is a very black and white way of thinking about things and that there are alternatives that are available, other possibilities. And then one that I think is very interesting, specific problem solving for discriminatory experiences. I've actually seen this used quite effectively in another area that I work, which is HIV, another stigmatized illness, where people have to deal with issues around disclosure and negative attitudes. And that actually having problem-solving interventions, helping people to work through, role play, anticipate, prepare for discriminatory experiences has been shown to be quite effective, certainly in the HIV area. I think it also has a lot of potential for people who are diagnosed with mental illnesses, just helping them to work through how to deal with these type of situations that unfortunately at this point are quite common. It does let the rest of us off the hook, unfortunately, but a little bit at a time, right? So the proposed scope of anti-stigma interventions for diagnosed individuals, and I put in brackets families, because of course families are also very affected by stigma. Structural interventions that looks at policies, laws, organizations, issues like employment. This is what I'm really proposing as a human rights focus in anti-stigma intervention. And then public health intervention, which I think is aligned certainly with the public education that is already in place, looking at mental health education and mental health promotion to create more supportive environments in our communities. And then individual and family empowerment by challenging discrimination and also strengthening their coping, empowering them to be able to deal more effectively with stigma that they may face in their families, in their workplaces, in their neighborhoods, in our society. So I'm going to end there. Thank you very much.